Bismillahirrahmanirrahim. So I have talked about the approach to myopathies, right, in which there is less muscular weakness, and if we check the tendon reflexes, those was intact, right. So I have talked about this thing. This if the patient is having muscular weakness and patient is having easy fatigability, so we're gonna think that the patient is having myasthenia gravis. And if the patient is having along with that muscular weakness and reflexes are intact and there are enlarged already enlarged muscles, so we're going to think that the patient is having congenital muscular dystrophy. So our today's topic is about the congenital muscular dystrophy. So I have already gone through the myasthenia gravis in the previous video, right? Okay, so after that we're gonna discuss about this the myositis. The patient is having pain at the rest, right? So let's talk about the congenital muscular dystrophies today, right? So let's talk about this thing, right? So let's talk about the first muscular dystrophy, right? So that is called as the Duchenne muscular dystrophy, right? What happens in this condition? This is because of the X. This is an X-linked recessive disorder. That means this is gonna express in the boys. So basically, there's an important protein, sarcolemmal protein, that is gonna connect the sarcolemmal to the outer membrane, right? So this protein is called as dystrophin, and if there is this protein is absent, so patient is gonna have the muscular weakness, right? So within that we'll have the actin and myosin, right? Okay, so this is basically dystrophin is basically the sarcolemmal protein, right? And there is gene deletion. That means this is a quantitative defect. There will be the absent dystrophin protein in these patients, and there will be no sport in these patients, right? Okay, so there is dystrophin gene defect, right? And this patient is going to present with the only enlarged muscles and muscular weakness, right? And this muscular weakness is going to start at 4 years of age, right? And there will be progressive difficulty in walking and running, right? And in these patients Gover sign is positive, right? So what is that Gover sign? These childs, they use their hands to climb up the body in order to stand up. So this is called as the Gover sign. If we check the calf muscles, so there will be pseudo hypertrophy of the calf muscles, and that is because of this fibrofatty infiltration, right? And if we compare it with another disease that is called as the Emery-Dreifuss muscular dystrophy, in that there will be calf muscle weakness in those patients, right? So in Emery-Dreifuss, so this is Dreifus, right? So this is Emery-Dreifuss muscular dystrophy. So patient is gonna have the calf muscle weakness, right? In these patients, in Duchenne muscular dystrophy, we're gonna see the pseudo hypertrophy of calf muscles, right? While Emery-Dreifuss, there will be calf muscle weakness, and patient is gonna have the toe walking, right? And that is because of the defect that is called as Emerin and Lamin. These are also the sarcolemmal proteins that are defective in these patients. So patient is gonna come. This is also an X-linked recessive disorder, right? Okay, so let's come back to Duchenne muscular dystrophy. So if we check the Gover sign, that will be positive in these patients, right? There will be waddling gait, heads actually head sways side to side while they're walking because of the weakness of the lower limbs, right? So they will be wheelchair bound by 10 to 12 years, right? So it's gonna start at 4 years, and the patient is gonna be wheelchair bound by 10 to 12 years, right? So they usually die of the congestive heart failure and pneumonia, right? And also diaphragmatic paralysis. Diaphragmatic paralysis is going to cause the cessation of respiration and pneumonia, while they can also die with the congestive heart failure. If we check initially, if we check the CPK mm values, they will be raised, right? And if we check later on, so this CPK mm values will be normal, right? And investigation of choice is, we can go for PCR for for dystrophin gene, and we can go for the muscle biopsy. right? So, and treatment is just supportive. We can give these patients steroids, and we can ask the attendants to do the chest physiotherapy in these patients. So they're going to come with the recurrent falls, right? So that's all about the Duchenne muscular dystrophy. Basically, let me revise it again. This is an X-linked recessive disorder, and there is quantitative defect. There is dystrophin gene deletion, right? And because of that, dystrophin protein is not there, and there will be weakness of the muscles, and this disease is gonna start at 4 years, and these patients are gonna be wheelchair bound by 10 to 12 years. And if we check the Govo sign, that will be positive. Investigation is just we're gonna go for CPK enzyme, and investigation choice is the muscle biopsy, and treatment is just supportive. If let's talk about the Becker's muscular dystrophy, right? So this is also an X-linked recessive disorder in which there is defective gene production, defective protein production. This is because of mutated dystrophin gene, right? So there is mutated dystrophin gene. Dystrophin is there, but that is malfunctional, right? So this is basically qualitative defect. So clinical features are just like that of patient is going to have just like weakness, and if we check the calf muscle, there will be a pseudo hypertrophy of that. That Duchenne muscular dystrophy, that is going to start at 11 at 4, while this in Becker muscular dystrophy, weakness is going to start at 11. And Duchenne muscular dystrophy, they usually die off by the age of 20, but here they're gonna die off by age of 40, right? Okay. And if we compare it with that of there is another disease that is called as this is Becker's muscular dystrophy. There is one disease that is called as Becker's disease, so we're not gonna confuse this with that of Becker's disease, right? So this is a variant of myotonia congenita, in which there will be sustained muscular contraction, right? So that is because of the chloride channel defect, right? There is also disease that is called as Thompson disease. That is also in that disease there is chloride channel defect, right? So let's talk about the another disease that is called as the Fascioscapulo dystrophy, right? So fascio means face is involved, scapula is involved, and arms are involved, right? So this is an autosomal dominant disease, and there will be iron out facial expression in these patients. There will be inability to raise the arms, and there will be winging of scapula in these patients, right? So this is very, and there will be these patients are gonna have the inability to puff the cheeks, right? So this is gonna start at the 12, and they usually die off by 40, right? So I think I have covered the muscular dystrophies in this video. So in the next disease, that is the myositis. In these patients, the patient is going to have the muscular weakness. Along with that, if we check the if we palpate the tendon, palpate the muscles, so there will be tenderness in these patients, or they're going to have the pain at the rest, right? So I'm going to talk about myositis in the next video. So that's all for today.